Thank you very much, Sajid. So I think my speech has been made very easy with the previous workers because there is a huge overlap, but I do apologize. When you say debut, when you look at the real meaning, I pitched it to the Sri Lankan audience, where the ones that we don't have, of course, I do apologize with our Indian friends. You all are using the newer drugs, so I have pitched some of them. And the drug that was not touched, she asked the question. So things have been very easy. My colleague Aravindan will go for the ones in development, right? So these are which have been FDA approved and in the threshold, and what we haven't got in Sri Lanka. For the benefit of our audience, I have put them to. So when they say armamentarium, it's a fight. So let's see which of these new molecules have the biggest punch. And they are blockbusting drugs and causing a huge interest in the diabetes world. I think this was also shown by a previous speaker, the Defonso in, I think, 2014-15 time. When we were students and all of us, I think it was increased insulin resistance or decrease in the production of insulin. The mismatch of those two were the causes of diabetes type 2. We were taught like that in medical school, but now you can see many other organs and systems, and central control of metabolism is huge. And as you can see, these newer agents are trying to tackle all these pathophysiological defects in the causing type 2 diabetes. And as correctly said before, most of our diabetic patients will die of a cardiovascular disease, or will end up with some of our cardiology colleagues most of the time. Their wards are filled with our patients. So nowadays, treating diabetes, although we have like 11 groups of drugs here, which you all are familiar, starting from the very basic metformin to others. In Sri Lanka, we don't have all the groups there, right? And so it's all about reducing the cardiovascular risk. So without being glucocentric, it's very important to control the sugars, but the larger picture, where you can give the biggest punch, would be reducing the cardiovascular risk in our patients. And then there are, despite all these medications, other than the GLP-1 receptor agonists and the newer ones, there were unmet needs for our patients. So the earlier ones, the conventional drugs, we will be reducing the sugars, and then they were getting hypoglycemia, they were gaining weight, and still they were dying of cardiovascular problems. So that's why the world moved towards looking at the other pathophysiological causes and try to reduce this cardiovascular risk. So looking at these factors, let's see. I think this was also mentioned. You can see the different groups of drugs and the areas that they work. And the ones in yellow will show that they reduce the weight as well. So a drug, in an ideal world, a diabetic drug which will reduce the weight, which will effectively bring down the HbA1c and will reduce the cardiovascular risk of your patient would be an ideal drug. Then comes the more lifestyle medicines where people don't like 3-4 injections a day. Like to get to the HbA1c that you deserve, we might have to give incretins, 1 injection, plus basal bolus, 4, maybe 5 injections. So people don't like that. So then comes the lifestyle medicine, where the convenience also comes in. So those factors also have been considered when you are developing these newer agents. I think Rakesh has done my job very well. He explained how these drugs are working and the multiple ways that they'll be effective. So my main focus here will be few medicines from the GLP-1 receptor agonist group, where the guidelines have put them at different levels, and now the latest ADA even as a first-line agent. I think this was explained beautifully by Kalra as well. These agents are prepared by tweaking few amino acids, maybe adding a albumin molecule to change the duration of action. and then they have made it from twice daily to once daily, and then once a week. Semaglutide, as mentioned before, has been the blockbuster drug, I would say, the most popular, sought after medication. I think they are running short of, in certain countries. People resort to different, and then these are all tied with weight reduction. All these anti-diabetic medication, the higher doses will be approved weight-reducing medication for non-diabetics, like the Wegovy or the higher dose semaglutide, or the Saxenda, the higher dose liraglutide, what we all discussed. So the newer ones, the once-week preparation, show sort of a regular it's a long half-life, and it works for about a week, and pretty much stable drug levels, which reduces the risk of hypoglycemia and the side effects as well. And that gives the summary again. I think this was also shown to you all, just to recap things. The different preparations, liraglutide is essentially a daily drug. And when the improved version, dulaglutide, it's intermediate, 4 days half-life. And the semaglutide, the latest, what Rakesh beautifully explained, is the longest that we have. And across the board, all these studies, SUSTAIN 1 to 5, and all these studies showed now earlier the SGLT2 hype, inhibitors hype. Empagliflozin, what's the HbA1c reduction? Less than 1. So all these molecules, they are getting like 1, 1.5, and touch close upon 2% reduction in HbA1c. And a previous speaker earlier showed that I think with metformin, a 1% reduction in HbA1c, what was the reduction in the cardiovascular risk and the death rate? So you can imagine with one medication how much you can gain. And of course, look at the weight. They were losing about 4 to 6 kilos, which is a huge achievement for our type 2 diabetics who are battling the weight problem. And it's a holistic approach that we had to take. And then the SUSTAIN 6 took the diabetes world by storm, and it showed that after empagliflozin, these medications were actually reducing the cardiovascular risk by 26%, and the number needed to treat is 45 for 2 years. So it's a very good number, cost permitting for us, and and all the other added things. So I think India, you're having Rybelsus or the oral semaglutide, which I was told is replacing, cost permitting again, even for you all, I think, is replacing lots of other medication, and a huge success. Imagine, no injections, just a tablet, and you achieve the same results as the injectable form. But I think at the moment, the only edge what the semaglutide injection has is the reduction in the cardiovascular risk, which the Pioneer 6 trial, which showed non-inferiority, but it didn't show a reduction in the cardiovascular risk. I think, which is at the moment, if the cost is the same, I would go for the injection at the moment, because it's all about spending so much money. It's worth reducing the cardiovascular risk. But of course, if it is weight reduction and, by way of reducing the weight, I suppose you can reduce the cardiovascular risk, but not directly by the drug. So this is the answer of that question you asked. The other sensation, tersepatide. I was there when they presented in the last ADA, I think, the SURPASS series and trial. So one company does have a blockbuster drug, and the other company say, why not? They are stimulating the GLP-1. Why not try the GIP, the other hormone, then put them together? Mind you, there are molecules in phase 2 trial trying 3 now with glucagon as well, twin or whatever they will call it. So this is like a twin creatine, tersepatide, So this was approved in the US, again causing a huge sensation. You can see the SURPASS series, where 1 to 5, they looked at all the data, and the HbA1c, you can see with the higher dose, right? We had to see how the Sri Lankans and the South Asians will respond, I suppose, but you can see 2.5%, 2.6% HbA1c reduction. It's wonderful. So it's like, even the cost-wise, we might have to give about 3 oral medications, metformin, sulfonylurea, and a DPP-4 inhibitor to achieve this reduction sometimes, So it's all about cost, but otherwise they are a wonderful thing. And the biggest sensation was the people there, when they presented, was not this. SURPASS was the diabetes and the weight, but there is another one for non-diabetic with SURMOUNT-1, which was presented, which went up to about somewhere near 20% weight reduction with the highest dose. But even in this study, with the glycemic control, you can see there is like a 12 kilogram weight loss. Of course, they were overweight and obese patients who went into the study. So I would say tirzepatide will be a huge success, a new kid on the block, making the debut in a grand way. But of course, we have to keep our eyes open for the side effects and the problems that may crop up later. And then so many studies are going on obesity, NASH, heart failure in non-diabetics as well. So a forgotten area, just to mention, this molecule also has come up, not noticed much. So there is a pre-type 1, I'm jumping from type 2 to type 1 now, and so you have stage 1, stage 2, and stage 3 in type 1 diabetes, and in people whose relatives are diabetic, you can look at the autoantibodies and the dysglycemia and predict the onset of type 1 diabetes. And anti-CD3 monoclonal antibody, teplizumab, given IV daily for 12 to 14 days, have shown at this at-risk study published. We have missed it during the COVID time, and we don't practice this, but the world is moving towards that also, which has shown a good result, delaying the onset of type 1 diabetes by about 2 to 3 years maximum. So we need to see how often that we might have to give. Of course, Sanjay has done justice to this molecule, degludec. We don't have it in Sri Lanka, that's why I put it. All what we have is glargine and detima, but in degludec, you all learned that it's a longer half-life, maybe 42 hours. And then what's the importance? The clinical importance is you could give it at different times of the day. One day you can take it in the morning, next day you can take it at night. So people who are doing shift work, pilots, traveling, all that, it's all about convenience, these new drugs. And as Sanjay was mentioning, they just tweak the molecular structure, put a zinc or a protamine or whatever the molecule, and change the pharmacodynamics so that they get absorbed slowly, either through the capillaries or the lymphatics, and then their duration of action changes. So please, Tresiba is the brand. I'm mentioning the brand because there's only one available. So you have the U100 and the U200, and you can go up to 160 units in that. So people who need higher doses, this will be a very convenient one to use. And then people start combining these drugs, the GLP-1 receptor agonists and the long-acting insulin, like this one, Ideglira or Saltopy, where people are trying to replace the basal bolus regimes with these medications as postulated given in this study. Instead of 4 injections, maybe you can get away with 1 injection, with some oral medication to fit in for the prandial insulin. Same as for IDEG aspa, so you have the insulin degludec, and then you put a short aspart, and so this is the mixed start we have, then we have the Novomix, and this is the next step called Rysodec. I know that's available in other countries, but not in Sri Lanka. Again, there are studies to show that we could replace in some people the basal bolus regime with these newer long-acting preparations. So that's the future. And of course, the weekly insulin, you all heard enough of it. And I will skip, and you can see the onwards program where it showed good results compared to, so it's 7 injections versus 1 injection. So that would be the convenience. And so the newer drugs are all becoming more convenient. They are reducing the weight. They'll have a better HbA1c reduction and cardiovascular protection. So that's the way forward. And I invite my colleague Aravindan to see what molecules will be there in the pipeline in the future for us to use. Thank you.